Thank you, Dhruv, for the nice introduction. At the outset, I would like to thank Dr. Chawla and other members of the organizing committee for giving me this invitation. I'll be speaking on a subject, it is actually in continuation with what Dr. Talwar has already introduced into various causes of NIV failure, because hypoxemic respiratory failure has been one of the conditions which has not been uniformly found to be successful with NIV. If you look into the history of non-invasive ventilation from early 90s, after the development of nasal masks for the treatment of sleep apnea, we have seen that it has been found to be significantly useful and beneficial for conditions like COPD, obstructive sleep apnea, hypopnea syndrome, and obesity hyperventilation. There is enough literature to it, and we have enough evidence, and in fact this is the first line of treatment in these conditions. Since then, and recently, there is an increasing use of this technique in acute care setting as a first line modality. However, it is effective in the treatment of acute respiratory failure, but its role in hypoxemic respiratory failure is still controversial. Now, if you have a patient of hypoxic respiratory failure who requires intubation and mechanical ventilation, we know that these patients have a very high incidence of ventilator-induced associated pneumonia. They have prolonged mechanical ventilation, increased morbidity, mortality. So, when you see a scenario like this, naturally there will be a recommendation for use of non-invasive ventilation in such situation, in order to avoid endotracheal intubation and its related complications, ICU stay and hospital stay associated, and other morbidities and mortalities. Now the question is NIV effective and safe in all forms of hypoxemic respiratory failure? Now, the first, I think the International Consensus Conference was held somewhere in 2001, under the aegis of American Thoracic Society, ERS, and European Intensive Care Society, where the expert tried to evaluate the role of this modality in hypoxemic respiratory failure. And they were of the opinion that the use of NIV does not consistently improve clinical outcomes in patients in this condition, and therefore it is not recommended. However, they observed that there are some select patients which may be of benefit, and their major concern was that large randomized controlled trials are required to determine the potential benefits and safety of this modality. Then subsequently, in the next 5-6 years, we had two very important surveys which were basically done outside clinical practice, and these surveys also found similar results. And if you see in the first one here, you see that they found that there was a benefit of NIV in patients with hypoxemic respiratory failure, that it prevented intubation in 62% of cases. And when they looked into the individual situations, they found that it was most effective in acute pulmonary edema with 82%, acute exacerbation of COPD, 76% patient avoided endotracheal intubation. But when they tried to look into causes of hypoxemic failure other than pulmonary edema, then it was not that good. The intubation success for avoiding intubation was only in 40% of the cases. And those patients in this category who were actually on mechanical ventilation also had significantly high mortality. The similar results were seen in the other, this was the study which was conducted in the French ICUs, and you found almost similar results. Now this is a forest plot of relative risk, which again shows, here the data was actually collected from a large number of patients from systemic reviews, and what it shows that non-invasive ventilation in comparison to invasive ventilation significantly reduced mortality in acute exacerbation of COPD and acute cardiogenic pulmonary edema. So there is no doubt that these are the two conditions probably which will get the maximum benefit in these with NIV. Now we know congestive heart failure, if you look into the pathophysiology, it is a combination of increased pulmonary congestion, interstitial edema, and pulmonary edema leading to atelectasis, hypoxemia. So in the initial phase, the patient has hypoxemic respiratory failure, and once it gets worse, the patient can actually go into hypercapnic respiratory failure. The use of positive pressure ventilation, we had a good talk in the morning about the pressure and the heart-lung interaction. It recruits alveoli. With the result, it increases. After the recruitment, it will increase the functional residual capacity. And once the FRC increases, the patient is shifted into a more compliant portion of the compliance curve, and patient breathes in a much better compliance. With the result, there is a significant reduction in the work of breathing. There is also an improvement in the ventilation perfusion mismatch. With the result, there is an improvement in the hypoxia and hypercapnia. The another very important role of positive pressure in these situations is that this decreases the preload and also decreases the left ventricular afterload, which is a very, very important condition in patients with fluid overload. Now, this positive pressure in acute pulmonary edema can be given by CPAP, which is considered to be the first line treatment in majority of these patients, but this can also be given by other pressure support or positive pressure modalities like BiPAP, pressure support ventilation, or volume control ventilation. But there is some controversy regarding their efficacy and safety. Now, if you look into the CPAP, we all know that CPAP is an established condition. CPAP is an established modality, and it is most effective. In fact, the initial reports date back to somewhere in as early as 1938, when simple pressure devices were used to treat pulmonary edema. Subsequently, no randomized control trials were done for the next 50 years, and then in the last 2 decades, we have large number of trials indicating the utility of CPAP in this condition, and it has been seen that it is very effective in improving the gas exchange. Even in patients with acute acidosis and hypercapnia, CPAP can be quite effective in the treatment. And it also results in reduction in the endotracheal intubation and mortality rates. But what about bi-level positive airway pressure or pressure support ventilation? The experience with these devices have been quite mixed. Some studies have shown no benefit. On the other, which have seen to be more complication, like some studies have seen that new onset myocardial infarction was seen more with the use of positive pressure ventilation. In some studies, we found only benefit in the symptom relief and oxygenation, that those where it was used in the emergency department, and no significant difference in the endotracheal intubation or mortality. But in a post hoc analysis, it was seen that the positive pressure ventilation is most useful in patients of acute pulmonary edema with hypercapnia and respiratory acidosis. There are the 3 trial which and also comparing CPAP, bi-level positive pressure ventilation, and oxygen in acute pulmonary edema. Here you can see that there are about 29 randomized controlled trials were taken, where 12 were CPAP versus standard therapy with oxygen, 7 bi-level PAP with standard, and then 10 studies compared CPAP versus BiPAP. And you can see from the results of this meta-analysis that CPAP significantly reduces hospital mortality and need for endotracheal intubation, whereas bi-level, there is no significant change in the hospital mortality, but there was a significant improvement in reducing the need for endotracheal intubation. However, comparing with standard therapy, neither CPAP nor BiPAP resulted in significant increase in the new onset myocardial infarction, and also it has no effect on length of the hospital stay. I think this is the one of the largest randomized controlled trial which has been conducted and appeared in 2008, which has compared oxygen, CPAP, and non-invasive ventilation with standard therapy. And what they have seen here, this results are a little bit contradictory here, that there is no benefit in endotracheal intubation or mortality rates. But what they found was that there was a rapid resolution of symptoms and correction of arterial blood gas, pH, in both CPAP and NIV group. The difference here was that most of these patients were treated in the emergency ward, and the average use of CPAP or non-invasive device was about 2 hours. Here, the outcome measure was entry into intensive care medicine. So, if you also look into the overall rate of endotracheal intubation rate, which was 3%, which is much lower than actually which is seen in the other studies. So probably the patients in this group, in this trial, cannot be compared with the patients which we have seen in the other trial. So if I have to put together the role of non-invasive ventilation in pulmonary edema, I can say that non-invasive ventilation is well suited for patients with cardiogenic pulmonary edema. CPAP and BiPAP modalities both are effective, with CPAP possibly being more effective. The greatest benefits are realized in the relief of symptoms and dyspnea. A decrease in the intubation and mortality rate is not a uniform experience, although it has been seen. And patients with hypercapnic respiratory acidemia may derive the greatest benefit from non-invasive ventilation. You can get the benefit as early as or with the smallest use of 2 hours, and particularly in the emergency department. Now the next question comes, now we know that in acute pulmonary edema it is quite effective. What about other forms of hypoxemic failure? There has been a considerable debate on the use of non-invasive ventilation in hypoxemic respiratory failure other than acute pulmonary edema. Now we have a very good meta-analysis by Keenan et al. In 2004, where they evaluated the role of NIV in hypoxemic respiratory failure, and they took all groups of patients, and what they found that there was a significant reduction in the endotracheal tube intubation, in the ICU stay, and also on the ICU mortality. But when in the interim analysis, when they excluded patients with COPD and acute pulmonary edema, still they found that there was a significant reduction, or the similar results were seen, that there was a significant reduction in the endotracheal tube intubation, in the ICU stay, hospital stay, and mortality. However, in this meta-analysis, there were some problems because it included only 10 studies, there were few studies, and there was a heterogeneous group of patient population, so strong conclusion could not be drawn. So the authors were of the opinion that there may be select group of patients who may be actually getting benefit from this modality, and they could be patients with immune suppression or with specific post-operative condition where you can use this condition. So we have the two very important trials, one in the immunosuppression, one trial which is basically, it is a randomized control trial of 238 patients which has been done in patients with solid organ transplant. Here you find that the use of NIV resulted in significant improvement in the gas exchange, reduction in the endotracheal tube intubation, as you can see here, and mortality, but there was no difference in the hospital mortality. The subgroup with cardiogenic edema fared best in this category. Then there was another category of immune suppressed patients, where you had patients mainly with hematological malignancy, neutropenia, the patients who were on immunosuppressive drugs, and those who are suffering from HIV/AIDS. Again, in this group, we found that NIV was associated with significant improvement in the endotracheal tube intubation, serious complication, ICU mortality, and hospital mortality. The important thing here is that in this group, when they came with hypoxemic respiratory failure, if you could know the cause of pneumonia early and could treat them, then this was the group who was found to have the maximum benefit. Now, what about ARDS and pneumonia? I think this is another situation where this modality is being used in the recent past quite frequently. Now, this is one area where there has been a significant debate. There is the debate because in this condition we have the maximum conflicting data.
Professor Suri, may I request you please to wind up because we are running late and there is a discussion. I hope you won't mind.
Okay, I'll just. So here you see that the patients have significant improvement in the oxygenation, to clinical improvement, to reduction in the endotracheal tube intubation. But here, one study, which was a first cohort study, which shows reduction in the endotracheal intubation, but what they found that the patients who have community-acquired pneumonia with COPD were the one who improved maximally than the other patients. Then the other study showed that pneumonia and ARDS were the significant risk factors in this. And then there was a conflicting study which shows again that the patients had improved with acute hypoxemic respiratory failure, but those with ARDS fared worse and those with pneumonia had the best result. So this is the most conflicting results we have in this situation. Those patients who come with early sepsis, early ARDS, these patients were found to have some benefit. You could see that here 54% of the patient avoided endotracheal intubation, and the predictor for success was basically low SAP score and low PaO2 FiO2 ratio and younger age group. So these were the predictor for success. So I will just go through this thing that this has been found to be useful in some post-operative patients. It has also been used as a weaning strategy. In the weaning strategy, basically there are three situations. One, if you want to do early weaning, this modality has been found to be useful, but only in patients with COPD. If you want to prevent post-operative respiratory failure in high-risk cases, this modality has been found to be useful. But if you want to treat post-weaning respiratory failure, this modality has not been found to be useful. In fact, it has been found to be harmful. So to conclude, NIV is recommended as a first-line treatment in patients with cardiogenic pulmonary edema and immunosuppressed patients with hypoxemic respiratory failure. It has also been found beneficial in preventing hypoxemic respiratory failure in post-operative patients following lung, cardiac and abdominal surgeries. May also be useful in preventing the development of respiratory failure following weaning in high-risk patients. However, it has been found to be harmful in treating respiratory failure developed after weaning and hence not recommended. It is also not recommended as a first-line therapy in the management of ALI and ARDS. ARDS. There is a limited experience, but it may benefit those who do not require immediate intubation. Successfully treated patients are found to have lower severity illness score, less than 34, and improvement in PaO2 FiO2 ratio of more than 175 after 1 hour. NIV is not established to be beneficial in patients with pneumonia, and improvement is best achieved in patients who also have COPD. Thank you for your kind attention.
Thank you very much, Professor